dialysis ke?
Satu dialysis lah, okey. So ada arahan apa lagi?
Tak ada.
Ada susah nafas ke?
Ada susah nafas sikit.
Can I get one assistant for me?
You have two assistant eh?
I have two assistant. Amina, please tell me to put a one car exposure for this patient. Amina, please tell me to maintain the area for this patient. I'm going to check the ECG for this patient. So before this, I will check for the TB. How about SCRT?
2 second.
2 seconds. Is it a increase of 1 or
Polish
2?
periphery.
May I know the disease? Disease looks like hypotension, so it looks like the patient not alert to the not alert to GCS, not full. So can I check for the lung any like cardiac effects?
Lungs minimal by pressure cracks.
Okay, sure. Any tibial edema?
Yep, a little bit edema.
So looks like the patient is in the unstable. I know the patient to have a complete heart block. Unstable complete heart block for this patient. I'm going to do the TCP for this patient. Please tell me to give an atropine for this patient 0.5 mg. What will be valid for TCP for this patient? Okay, Amina, good. Please help me to make it. Okay. Check for the blood. Send for the blood test. I want to look for any electrolyte imbalance for this patient. And send a 1 mg and then check. Okay. Atropine 0.5 mg. Encik ada arahan buat apa tadi?
Ada.
Ha?
Ada.
Ada. Okay. So please give the atropine 0.5. So I will do a pacing for this patient.
Atropine given.
Okay. So how about extra cardiac monitoring after given the atropine 0.5 mg? Looks like patient stay in the complete heart block. Can I get an available blood test for this patient? Will look for any hyper or hypocaine?
Potassium 6.5.
6.5. So the patient having a symptomatic hyperkalemic unstable. Okay, please tell me to give a diabetic protein for this patient. I want 50 cc of calcium gluconate 10%. Give 50 cc of dextrose 5%. Also the extractive 10 unit. So
Leticotilibin.
please make sure the cardiac monitoring is on what? And that can help. If the patient can able to maintain the ventilation. How about my airway patterns?
Patient can talk to you.
Okay. So after one cycle of lactic appear, I know the cardiac monitoring but still having a mistake. So I'm going to do a TCP for this patient. First, Encik saya dapati Encik ada masalah jangkitan jantung yang lemah. So saya akan buat satu prosedur kita panggil pacing. Dia akan rasa tak selesa sikit tapi rasa kita akan bagi buat tahan sakit lah. So I want to give fentanyl 50 mic and IV midazolam 2.5 mg. So looks like this patient, this machine doesn't have any pacing, so I put the cardiac tag for the birth for the anterior posterior and also the
If you don't have pacing, what else you can do?
I would like to use a pharmacological pacing. So first I want to use adrenaline. I may use a dilution of 3 mg in 50 cc D5. So it's equal, I adjust to 1 ml per hour equal to 1 mic per minute. So I give a range about 5 to 10 mic per minute for this patient. So can you help me to prepare the dilution of IVI adrenaline for the pharmacological pacing?
adrenaline.
So and also the patient's having a VF. So please line up the patient. Please do a check compression for this patient. So I'm going to repeat for this patient. So I say 200 do for this patient. So please continue CPR for this patient. I'm going to repeat of this patient. So charging. Okay, I'm clear, CPR clear, oxygen clear, everyone clear. Stay in VF. So shock delivered, continue CPR. Continue CPR position. Please make sure having a high quality CPR with a depth 5 cm. Then rate is 100 to 120 compression per minute. Allow full chest recoil, avoid minimum interruption, and also please make sure avoid hyperventilation. Okay. We going to change the compressor and ventilation in 30 to 2 ratio. Okay. Right. So set for the blood gas. Any hypocaine? Is there any other blood availability? Any acidosis?
It is 7.1 bicarb 15.
Okay, I would like to get another assistant to give a sodium bicarb 8.4%, 100 mils. Okay, I I get someone to get any toxin, any like to get history for the history regarding any toxin, any drug overdose? Can I get my focus? Can I get my bedside scan available?
Focus on available.
Okay, good.
2 minutes is up.
Okay. So CPR, we assess the leader. Still having BF. Okay. Please continue CPR. I will wait to repeat another patient. Okay. Off CPR, off oxygen. Okay, underline here. Okay, still BF. Short delivered. Continue CPR. Okay, good. Please help me to prepare IV amidon. Just first, just standby. And I get someone to give an IV adrenaline 1 mg step given. Okay, good. Please make sure, how about my ventilation? Is it adequate?
Yes.
Okay. Please continue CPR, continue CPR, continue CPR. Is it my scan available? Not yet.
Available.
Not available. The repeated blood gas, is it any evidence of hypercare?
Still pending.
How about my DSP?
5.5. Okay, 2 minutes up.
Okay, assess leader. Still BF, so I'm going to defect an application 200 low. Here. Okay, clear. Every oxygen please clear. Everybody clear? Short delivered. Continue CPR. Please check IV amidon 300 mg bolus. Yeah. Like you see, we need to incubate the patient. And then please tell me to prepare for the advanced incubation site for this patient. Okay, good. Thank you very much. Can I know the latest blood gas for this patient? Any
Okay, 2
others?
minutes up.
Okay, since there is an organized rhythm, so any pulse rhythm?
Fast probable.
Okay, so look guys, we have been successfully resolved for this patient. So we are going for the airway and breathing. I'm going to start the lung protective strategy with tidal volume is 6 to 8 mils per kilo. So with the rate about 10 to 14, make sure the I is 1, 2. Hit the peak breath is less than 30 and running tension less than 15. For the breathing, I would like to take a blood gas to make sure normosonia. P0 to 35 to 45, and also keep the S2 to 94 to 98%. Connect to the ventilator with the oxygen wall. Okay. Then for the C, how about the BP? BP for this patient, 80 or 30. I would like to give 1 liter of fluid. If not, but this patient having end-stage stroke is contraindicated to fluid, so I'm going to start the early antidote for this patient. I'll use a double strength of IV adrenaline, ANT in 50 cc. So please help me to give the antidote for this patient. Okay, good. For the D, I want to keep ambient for this patient. Go on the ice tube CBD, but I want to make sure the patient having whether it's coronary or anemic for this patient. Then PPI for this patient and also sedation. In this case, I use the D-fentanyl because the patient has renal failure. And the last one, I would like to refer to the medical or nephrotin. Maybe the patient need early RT for this patient for the factory company.
Okay. Alright. So comment. Stop here. Any comment?
Ready. So she requested for pacing, but pacing is not available. So NCOT punya dose for atropine berapa? Kau 0.5
Kalau ACLS, kalau AHA? 1 mg, ya? Okay, so but you ordered 0.5 mg kan? Okay, the total maximum?
3
Okay. So kalau you support 0.5 ataupun 1 mg acceptable lah. Okay, kalau you guna AHA 1 mg up to 3 mg. Okay, lepas tu daripada ada secondary to hyperkalemia, so she corrected the RPK and then patient become VF kan. So you manage VF accordingly. Okay, so in terms of the post ROIC care, I think you go straight follow the AHA senang sikit. A, B, C, D. A tu apa?
Airway,
So the way,
ventilation.
you just mention kata connect to the ventilator, connect to the capnograph first, connect to the capnograph and ventilator. That's it. D is BP. So you look at the BP hypertensive, sama ada you bagi fixed, then plus minus you start with vasopressor. So you sebut inotrope kan, so you start vasopressor, and then the third one C is cardiac. So you ask for 12 lead ECG. Alright, so because that is another a part of HMTs kan, so you have to see coronary thrombosis. So C tu you order for 12 lead ECG, and then if we give you ECG, you have to interpret ECG. If MI, then you call for PCI, right? And CCU. And D is targeted temperature management. Kan? So what's the range for TTM?
32 to 36.
Itu engkau. 32 to 0. Okay, kalau AHA? 32 to 37.5. So that's for latest guideline 2025. Okay, that's all for the ACLS. Itu biasa standard ACLS. Maksudnya tak ada lah much of the interpretation of the ECG, tapi you will dwell a lot on the pacer.